Hi everyone. Almost the last stretch, right? Hanging in there. I'm Irbaz. I'm a GU medical oncologist at Mayo Clinic, Arizona. And my second role at Mayo Clinic is I lead the data science and AI working group at Mayo Cancer Center. So talking about bladder cancer, I'm just going to test my stuff. Okay, good. Works. So much new is happening in bladder cancer, across all oncology. So how do we consider balancing efficacy and toxicity for these agents? So historically, for the first line, metastatic or advanced bladder cancer, the paradigm sort of stayed between, I'll just pass it on here and put it here. Is the patient cis eligible? Good performance status, good kidneys, neuropathy and ototoxicity minimal, adequate cardiac function, and ineligibility. So the decisions of treatment really hinged between if somebody is cisplatin eligible or ineligible. If cisplatin eligible, we used to offer cisplatin-based chemotherapy. If cisplatin ineligible, you could do carboplatin-based chemotherapies, gem-paclitaxel, EV-pembro was an option, or single-agent IO if chemotherapy not eligible at all. For patients who received platinum-based chemotherapy and had stable disease or response after 4 to 6 cycles, then they went on nivolumab maintenance. So cisplatin eligibility was a key paradigm or a question that helps decide how to treat in the first line bladder cancer. But chemotherapy is not easy to give. 1/4 of patients did not receive first-line therapy. This is actually Dr. Sampavde was presenting earlier, so this is the data he presented. And half of the patients did not receive second-line chemotherapy. So it tells us that we had treatments, but not all of eligible patients were getting them. When they were getting them, in the first line, 40% of patients received cisplatin-based chemotherapy, 25% received immune checkpoint inhibitor single agent. And this is the data for the later lines. So how has the treatment landscape evolved? So bladder cancer, cisplatin chemotherapy or platinum-based chemotherapy was the standard across many, many years. We really had nothing. We had lots of trials, but nothing. We really couldn't move too much beyond platinum-based chemotherapy. However, last year or so, we have had 2 new combinations. EVP, I would say the groundbreaking combination, and GemCis plus nivolumab, both shown to improve overall survival. Big deal. All those years when we're stuck with platinum-based chemotherapy, within the last couple of years, we have 2 new frontline combinations in the first line with overall survival benefit. EVP has sort of become the standard. We'll talk more a little bit. So how would you treat now for advanced metastatic urothelial cancer? EVP for most patients, or you can use GemCis platinum-based chemotherapy with nivolumab, or chemotherapy platinum-based followed by avelumab maintenance. 3 frontline options. Most patients are probably now getting EVP, and I'll show you why. Once patient has received a frontline treatment and there is disease progression, we have these options. I'll come back to that in a little bit. So this is the groundbreaking EV302 trial. Patients were randomized to receive EV-pembro or cisplatin-based chemotherapy or platinum-based chemotherapy, cisplatin or carboplatin. If you look at the inclusion criteria, it's fairly broad. It's basically previously treated metastatic or advanced bladder cancer, eligible for platinum, cisplatin or carboplatin, adequate renal function with GFR of more than 30. So this is an important factor to keep in mind. Results are very impressive. So at 18-month mark, patients who received EVP, 44% were disease-free or alive, as opposed to 11% on chemotherapy. hazard ratio 0.45. It works across subgroups, if you look at the data. Works with patients who have upper tract disease, liver metastases, regardless of pedal expression, regardless of cisplatin eligibility, regardless of sites of metastasis. Consistent activity. The results translate into overall survival. Dr. Sampavde showed you the updated data from GU, quite similar again. At 18 months, 70% of the patients were alive as compared to 45% on chemotherapy. Hazard ratio 0.47, very impressive. Again, works across subgroups. You see, everything is to the left of this null effect line. Works consistently. Also impressive is about 30% complete response in EVP patients as opposed to only 12% complete responses in patients receiving chemotherapy, and about 70% overall response as opposed to about 45%. So really, the combination is active. For a combination that is this active, doubling overall survival in the history, first time in the history of bladder cancer, it's easy to say that this is a very active regimen, impressive regimen. How do we give it is the most important question. How can we give it effectively and safely to the patients who have bladder cancer? Grade 3 events were about 56% in the EVP group and 70% in chemotherapy group. So fewer grade 3 or higher events, but the key is the side effect profile is different from chemotherapy. Here, the side effects are peripheral neuropathy, rash, neuropathies, rash, and ocular toxicity and hyperglycemia are four of the main ones that we need to keep an eye on. So I've highlighted here. We need to keep an eye on neuropathy. Happens in about 3.6% of patients with grade 3 or higher. Rash, 7.7%, grade 3 or higher. Hyperglycemia, about 5%. So important toxicities to keep in mind. So clearly, this is a transformative regimen. The question isn't whether to give it, but how to give it most effectively and safely is the key question now. We talk less about that, but this is where I'm going to focus most. So the starting dose of EVP, or I'll focus on EV. Pembro is standard. We all know pretty much. We have given it for a long period of time, so now we're comfortable. For EV, 1.25 mg per kg is the standard dose. It's given on day 1 and day 8 or on 21-day cycle. So these are the level of reduction. You go from 1.25 to 1 or 0.75 if needed. Again, relevant toxicities we need to keep in mind: neuropathy, itching and rash, hyperglycemia, fatigue, infusion-related reactions, and dry eyes. And we need to learn how to manage them so that we can keep giving this effective drug. So balancing toxicity. For skin rash, the onset is typically during cycle 1 to 4. It happens early. Because it's given as a combination with Pembro, one can always be confused whether the rash is from EV or Pembro. Pembro rash tends to happen a little bit later, doesn't respond to dose modifications. EV rash tends to happen earlier and responds to dose modification. For the grade 1 rash, you may consider dose interruption early. Be proactive. What we do at Mayo is we prescribe patient triamcinolone lotion, not the ointment. Lotion you can spread over a large surface area, and we give a lot of it to the patient before we start EV. We write like 180 ml, not the 60 ml that you will usually get. You can get, we give them lotion, a lot of lotion, so that at the first sign of instance of rash, they can start applying it. And we also give hydroxyzine for itching. So the moment patients start having the side effects, which most of them have, they can start taking lotion, they start applying lotion and start taking hydroxyzine without waiting. For many patients, the rash will actually resolve, and then we can restart one dose lower level. This really helps prevent escalation into severe dermatitis or blistering. Common mistake is keep pushing the drug through rash, and then it becomes severe and then leads to treatment discontinuation. So if the rash is not responding to lotion and hydroxyzine, then obviously you can stop the drug and resume it at a lower level. So we try to be proactive. Peripheral neuropathy is cumulative for EVP, for EV here specifically. It happens a little bit later because you need cumulative dose. It's different from platinum-induced neuropathy. Platinum is more like sensory neuropathy. For EV, it's both motor and sensory. It may cause coordination issues, not just numbness and tingling. So there's a flip-flop test. So you have those flip-flop slippers. If patients can wear them and squeeze their toes around them, they're doing a good job. You can still sort of keep giving this drug. If you can start seeing coordination issues with inability to handle those flip-flops, that means your motor neuropathy is setting in and you need to be careful. Again, dose interrupt at grade 1 early, hold for 3 to 4 weeks, then resume at a lower dose. This approach prolongs treatment duration while preserving neurologic function. Ocular toxicity, it's basically dry red eyes, again happens early. I also send them with artificial tears so that the moment they have it, they can start using it. Again, it becomes worse over time if not managed properly. You could send them for ophthalmological exam, but it's not necessary for EV. It's more for erdafitinib, but it's an option. I usually don't get a baseline ophthalmology exam because the mechanism of action is Nectin-4 is in cornea, expressed in cornea. So it causes dryness of the cornea, which can be handled very well with artificial tears. So again, I wanted to highlight the ocular toxicities of EV and erdafitinib because we're also going to talk about erda because it's given in the later line bladder cancer. So here for EV, it's dry eyes and keratopathy. Here it's retinal issues. This is extraocular issues because Nectin-4 is expressed in cornea. So you really don't need baseline eye exams here. You manage by lubricating the eyes, and it generally responds well. With erdafitinib, the ocular toxicity is more serious. Ophthalmology exams are mandatory. Can be vision threatening. This is usually easily manageable if you stay on top of it from EV. Hyperglycemia, it can cause to worsening of hyperglycemia in diabetics or patients who are pre-diabetic. It can happen with any time without any diabetic predisposition. It seems to be off-target effect. And then for immune-related AEs, for pembrolizumab, I think we're generally familiar, so I'm not going to spend too much time on it. Less common issues, nausea, fatigue, ILD. Alopecia happens quite frequently, actually, but it's not very severe. So it's fairly mild. So balancing toxicity with this regimen is don't push through toxicity. It's more drug is not necessarily better outcomes. I think there's something about EVP combination which alters the tumor fundamentally. So it's important to sort of manage the toxicity well so that we can keep giving this drug. So take your foot off the gas when toxicities emerge. Let toxicities recover, resume at one step lower. The goal is to prevent permanent discontinuation by early management. Important distinction, unlike chemotherapy, EV does not have major issues of nausea, fatigue, bleeding, kidney dysfunction, sepsis. It's again sensory motor neuropathy, hyperglycemia, rash, and hyperglycemia in some patients. So this is the data for the GEMSIS Nivo trial. It's a second option now in the first line setting, EV Pembro, as well as GEMSIS Nivo. Both trials were presented together. Two phase 3 trials, positive after decades and decades in bladder cancer. So this trial sort of got less attention and less accolades as compared to EVP. It's a little bit unfortunate for this combination, but it's a good problem to have. So here patients were randomized to either chemotherapy or chemotherapy with GEMSIS plus nivolumab. And then dual primary endpoints of PFS and OS. Again, the data is fairly impressive. Not as impressive as EVP, but still pretty impressive data in the context of what we've seen in the bladder cancer. So hazard ratio of 0.72 for progression-free survival, and hazard ratio of 0.78, again statistically significant for overall survival. Again, it works fairly consistently across subgroups. The response rates are about 58% as compared to 43%, And again, complete response in about 1/4 of the patients, 21% as opposed to 11%. So, even with this combination, you have at least 20% patients with complete response in metastatic bladder cancer. Very impressive. Nothing that we have seen before now with EVP and Gemcis nivolumab. Again, the toxicities here are nothing novel about these toxicities. Most are driven by chemotherapy and nivolumab. We're quite familiar with those toxicities, so I wouldn't really talk too much about it. So again, now for the frontline treatment of metastatic or locally advanced bladder cancer, these are the 3 major options. EV pembro preferred in most patients, Gemcis nivolumab combination, Gemcis nivolumab followed by nivolumab maintenance, and platinum-based chemotherapy followed by avelumab maintenance. It's really hard to find patients who are not EVP eligible. Actually, for about 90% of the patients, EVP will be their first line option. If you're worried about neuropathy from EV, you are worried about the same neuropathy with chemotherapy. If you're worried about uncontrolled hyperglycemia, you would also want to control hyperglycemia before giving chemo. So, you could give it to most patients. Actually, I just gave this combination to a 90-year-old patient, and the patient is doing fairly well. Once the patient received any of these in the front line, then these are later line options. Now I'll start going to the details of erdafitinib and especially T-DXd. Second or late line therapy. So I'll start by talking about erdafitinib. Again, this is a drug which has overall survival benefit in the right setting, but also very difficult to give because of toxicities. So I'll talk a little bit about the toxicities. So what's the indication for erdafitinib? Erdafitinib is indicated in patients who have locally advanced or metastatic urothelial carcinoma with susceptible FGFR3 genetic alteration. So you need to have FGFR3 alteration, not 2, 3, FGFR3. FGFR2, it had an indication previously for FGFR2 alteration. Now it's only FGFR3 based on the phase 3 data. And patients must have progressed on IO for them to get erdafitinib in first line. So if you had EV pembro in the first line, pembro qualifies and you could move to erdafitinib if the patient has FGFR3 alteration. So third trial had 2 cohorts. FGFR alterations were necessary. Patients should have at least 1 or 2 lines of therapy. It had 2 cohorts. One cohort had prior immunotherapy with PD-1 or PD-L1, and cohort 2 did not require prior immunotherapy with PD-1 or PD-L1 inhibitor. And the reason why this is important is because it was this cohort in which patient had prior treatment with PD-1 and PD-L1 inhibitor in which there was overall survival benefit. And hence, the approval is for this cohort, or this cohort of patients who have received immunotherapy prior in the front line, either a single agent or with EV, and now progressing an FGFR3 alteration, erdafitinib is an option. This is the cohort which shows erdafitinib versus chemotherapy. Previous IO has a ratio of 0.64 for overall survival. Again, this is the cohort, erdafitinib versus pembrolizumab, no prior IO, hazard ratio is 1.16, not statistically significant. So you got to have received previous IO to receive erdafitinib in patients with FGFR3 alteration. This is the PFS results. Again, there's about 6.6%, about 6% response rate, complete response rate, and about 40%, partial response rate. So this is an option. 6% of the patients, you're going to get complete response with overall survival benefit. So now it's really important that we can give this drug safely. So the main side effects are for the erdafitinib are essentially listed here. We need to learn how to manage hyperphosphatemia, diarrhea, stomatitis, ocular toxicity, dermatologic and nail toxicities. So you start with 8 milligram dose, and then if the phosphate levels remain adequate, then you move to 9 milligram dose. And then for stomatitis, you need to be aggressive with mouthwashes. You could do magic mouthwashes, topical steroids, and you need to do dose interruption. Again, ignoring phosphate level can rise to ocular and soft tissue calcifications, and delayed management of stomatitis can cause those interruptions and efficacy issues. This is the summary for erdafitinib toxicities: hyperphosphatemia, stomatitis, diarrhea, central serous retinopathy. So actually, most of the patients that I've given erdafitinib, they had ocular dysfunction, they had retinal detachment. So you need to be really proactive when giving this regimen. So you need to listen to the patient. So like I said, almost all patients that I've given erdafitinib to led to retinal detachment, and then these are reversible though. So you stop the drug, and the reason why this happens is because there's fluid accumulation behind the retina from this drug, and once you stop the drug, the edema resolves, and that's reversible. So finally, the last drug is trastuzumab DXd. I'll just quickly mention that this is only eligible for patients who have IHC 3+, and this is a blanket indication. This is not bladder-specific indication. If a bladder patient has IHC 3+, then trastuzumab can be given. The major side effects are nausea, blood issues, and lung issues, interstitial lung disease. So you really need to have a strong prophylactic anti-emetic regimen, and stop immediately if there's pneumonitis. So this is the summary slide again. Patients with advanced or metastatic urothelial bladder cancer, frontline options, EVP is preferred, and after progression of the frontline with any of these drugs, if FGFR3 alteration, erdafitinib. If EV was given before, you can give platinum-based chemotherapy. If HER2 positive and no other alternative treatments, it has to be 3+ on IHC, then you can give trastuzumab deruxtecan. This again, there are some questions that you can review at your own pace. Thank you very much. And I can also take the questions now, or I think at a later time. Thank you.